Good afternoon, all. We are very glad, and it is honor for us to have a round table about a hot issue of public health. We're discussing now a new gaze of public health, and with us is Professor Ikonomidis, a president in this table, and three distinguished experts, professors in this hot topic.
I would also like to thank the organizing committee and Professor Barbouni. With her and the next speaker, Dr. Richter, I have the pleasure to operate in SCOHRE, in the Smoking Cessation and Harm Reduction Control Association, and I'm sure this is going to be a very good continuation of the previous roundtable discussion, how we can improve public health. And this session has a focus on smoking cessation. And just to spare time, I would like to introduce Dr. Dimitri Richter. He is the head of cardiology department in Athens Euroclinic. He was a past chair of the Council of Clinical Cardiology of the European Society of Cardiology, and I'm sure he will have very interesting things to present to us. Dr. Richter.
Dear professors, dear gentlemen, dear colleagues, the next 10 to 15 minutes, I'll try to give you which is the regulatory frame that we have for all the new tobacco products. As we well know, this is a new reality we have practically. We have new tobacco products that are different from smoking. It's very difficult to say which exactly their position must be. And what is really important for doctors in order to be able to give an advice, because smokers come to the offices or to the special centers and they ask a lot of times, I'm not ready to quit. I heard about the new products. Are they really less harmful? So let's see what exists globally. I will start with USA, in which we have, I believe, a quite good program. And this is something that probably should also expand to Europe, in the sense that the FDA, one of its mandate is to check also tobacco products and not only on drug products, something which doesn't exist for the EMA in Europe, in which he has only to regulate drugs. And as we will see, he gives, when we give tobacco, there are various kinds of permission in the United States. The first is the permit to circulate as tobacco product, because the last 10 or 15 years, we have a regulation which says that for a new tobacco product, in order to be able to circulate in the United States, it needs to be less harmful than the existing ones. So first you need to get a permit to circulate as a tobacco product. Then you can have, if the file is accepted, and this is a file exactly like the drugs, a permit to circulate as tobacco product of reduced harm. And then we have the possibility of having a reduced exposure claim, which means reduced exposure at harmful substances, or a reduced risk claim, which is a reduction of smoking-related disease risk. Reduced exposure claim theoretically will lead to reduced risk claim, but it will take decades to prove it. So the FDA has two different definitions for this. And as you see, the file is a complete file of product analysis, non-clinical studies, studies in adult human subject, and also secondary data analysis and computational modeling, in the sense that they investigate even the way consumers feel about it, and if it can be attractive to non-smokers, because what the FDA is trying to prevent is people becoming smokers of the new product. That's not the idea. The idea is to try to go from smokers who are not able to quit to bring them to less harmful products. And as you can see, since 2019, IQOS got a permission to be on the market as in the United States. And in 2020, it got a reduced exposure claim. In snus is the only product that got a reduced risk claim. And at the same time, we see the first e-cigarette, 2021, getting the license. We have to say that on e-cigarettes at the beginning, they were not considered tobacco products, and they were under a different regulation. So practically, there was no authorization on them. After the Valley disease and all the deaths and the permanent lung damages that happened in the United States, the FDA asked all the cigarettes that they have to be regulated as e-cigarette machines, as liquids, as everything, and they need all to make an application. Vus was the first one who got a permission on this. And as we see, the October 19, this is the first time that FDA granted snus a lower risk claim of mouth cancer, heart disease, lung cancer, stroke, emphysema, and chronic bronchitis. And this is mainly due to epidemiological studies that we saw in Sweden and the Scandinavians, in which snus is very often used, something that we don't have in Europe because it's not permitted. We see IQOS that got a reduced exposure, a system that hits tobacco but does not burn it, and reduces the production of harmful and potentially harmful chemicals. And in an article I had in the European Society of Cardiology, a journal, one of my proposals is that Europe probably should follow FDA's example and try to have a unified authorization and a unified for all countries way to go forward, because at the moment each country has a different legislation. And what is really, from a medical point of view, interesting is the snus, because we see that it's the only product that really gets a reduced disease claim, and at the same time it's not permitted to circulate all over Europe except Scandinavia, but at the same time, we can continue to buy cigarettes. In Europe, we have the Tobacco Product Directive. It came out in 2014. It was the first time in which we had an exact definition of which product is which. You see, when we got the novel tobacco products, the electronic cigarettes, and we had changes. The changes that the smokers see every day in their life, they came from this TPD. For example, this picture with a disease in which it has to be 65% of the surface area and is a picture and text warning. This was done by TPD, and the fact that we don't have slim or light cigarettes or small packets, it's again on TPD. We had an exact definition of novel tobacco products, and it was decided that they need to notify 6 months before intending placing on market exactly all the studies to each country before going directly on the market. On electronic cigarettes, before 14, we had no information practically and no maximum volume or concentration of nicotine, something which happened after 2014. And that's one of the reasons Juul was initially not able to circulate in Europe, because the quantity of nicotine was higher than that permitted. And we see different countries have completely different way of acting on that. New Zealand seems to be positive to the new products. They continue with their plan by 2025 to have 5% or less of the population to smoke. But Also, they start making notifications to the public that completely replacing your cigarette with a vape will reduce harm to your health. So they get this British compassionary approach. In the European Union, we have different rules for the products according to the TPD. Italy, Bulgaria, and Cyprus, we see that we have regulatory frameworks for science-based communications on relative risk and harmful chemicals. They got approval to be on the market in all these countries, but each country, there are countries which have the possibility to get a reduced risk claim and others which do not have. This is completely country dependent. Norway saw it positively because they realized that trying to exclude these products, these new products from the market could increase the consumption of cigarettes. In Greece, we have a new law since 2020 which covers practically all these parts. And what's really interesting is that it gives to smokers the possibility to be informed about the various products. They need to be scientifically evaluated first, and we have a 7-person scientific committee from the Ministry of Health and from doctors and various professional organizations in which they will make a comment that if each product can make a claim for damage reduction or not. We see from Japan, a country which traditionally had a very high smoking rate, that the more the new products come into market, the number of smokers become less. So this was a positive sign for the Japanese state. And what's really interesting is the United Kingdom approach, because a completely different approach. They have the harm reduction as a strategy used in medicine and social policy to minimize harm to individuals and the society from hazardous behaviors. And it's seen as additional and complementary to tobacco control measures. And we see that we had a consensus on e-cigarette from the public health and various scientific organizations that these products can be helpful because they can reduce the harm and they are least harmful, especially for people who are unable or don't want to stop. And we see the Royal College of Physicians, which made this comment by the idea of getting from most harmful nicotine delivery system to less harmful nicotine delivery systems. And we see that the communication that comes to the public with that is a positive for these products in the sense that they comment that these cigarettes are less harmful than smoking cigarettes and they can help you quit. We see that in the United Kingdom, we have smoking and vaping trends that vaping, the more we have vapors, the less smokers we have. So that's a change in the everyday life in the United Kingdom. And what I really like is the really practical approach. They realized that in England, of 100 smokers, 36% tried to stop in the last year. But the real success rate was 25% of them were able to wear abstinent after 1 year, which means 91 smokers out of 100 continue to smoke. And these are people mainly from deprived and disadvantaged groups. So that means people which have also other risk factors in which they are more difficult to maintain their health. And Mike Russell is, let's say, the father of this compassionate approach. And he was highly critical of the government's approach 20 years ago to reduce nicotine in cigarettes, because then smokers would compensate and smoke more. This is the belief that nicotine is also, it's harmful, but it's not the most harmful product. And practically, we need to use nicotine in order to be able to reduce the damage people get. People smoke for the nicotine, but die of the other substances practically. So the general idea in the United Kingdom is that they get the aim to reduce the death and disease caused by tobacco use, and they don't put as main part to reduce addiction to nicotine or to eliminate tobacco industry. We see that between Europe and United States, we always have a lot of differences in the approach, in the various ways of thinking. But this time, I believe United States, by adding to FDA the possibility to use the regulatory approach of FDA also to tobacco, they made it probably better than us, that on this we always have only national policies. And as you know, Europe is very effective and very bureaucratic in all their parts. Thank you very much. Professor Ikonomidis.
Okay.
Thank you very much, Dr. Richter. I think your arguments were very persuasive that there is a trend nowadays, at least in USA and Japan, and of course in United Kingdom, that is the leader, in presenting harm reduction policies. And in a way, FDA, by accepting the reduced exposure, has adopted, and by accepting the reduced risk from snus, has accepted the notion of harm reduction policy in smoking. What do you think? Is this something that can prevail in the European Union or also in the various scientific societies, medical scientific societies?
You mean the idea of harm reduction?
Yes.
I think it should become something European. I mean, it's true that it's very difficult for medicine to know that all these products are the alternative, and the alternative is to continue to smoke, because when somebody is unable or doesn't want to stop smoking, independently of what the doctor will say, the result will be the same. So I believe we should have a global European mandate on this and have a global policy to discuss about risk reduction, to discuss about disease reduction, and to be able to communicate this better to people, because the public needs to hear an official voice, and I believe that's very important.
Yes, I think you're right, and this is in line with other policies to reduce, for example, sugar, to reduce lipids in food. This is something similar, and I think it is a policy that should be adopted. We have so many, for example, I'm a cardiologist, you are a cardiologist, we have so many people with cardiac diseases that are unwilling to quit smoking. So we have to offer another opportunity to them to replace and to reduce harm, and not just stay in the background and stating that you have to quit smoking, and if they don't quit, just overlook about this behavior.
Exactly.
I don't know if Natasha has another comment.
No, I want to thank you, but now we have in our basket the idea of a new area. We have a new reality. We have to face on it to see how to use it in the public health regulatory. So it is very important to discuss it and to have data and a strong regulatory, maybe in Europe area.
Yes, of course. What do you say, Dimitri? Are there any studies on the way on these smoking products that could offer more evidence?
We have studies because, as you also saw, and you know it better than me, the FDA would never accept it as a reduced exposure without studies. The problem is that for the moment we have the few years that we have these product studies which show that we have a reduced exposure to damaging substances, but in order to get studies that will show us that we have a smaller disease risk, it will take decades. Snus was able to do it because it has data from the 70s in one of the countries with the best recording system as Sweden. So it was able to give us all this data. I believe we need to accept the reduced damage as concept. As doctors, we always need on the first line to ask people to stop smoking. But at the same time, if they fail, we need to be compassionate and try to help them go to the less damaging solution and not just tell them it's your fault, you're going to die because you are unable. I mean, they know it. We need to do something better on that.
Yes, and in terms of public health and public cost to support this habit, which is quite dangerous and may lead to a second or a third cardiac or stroke or cardiac event or lung cancer eventually.
I agree.
Anastasia, is there any question from the audience?
No, there isn't any question, as I can see.
So maybe we can carry on with our next speaker. Who has evidence, I'm sure, about snus and how harm reduction policy gave results in terms of disease. And would you like to present him, Anastasia?
Yes, he's a famous, very famous professor, Professor Fagerström, with scale. Everyone will have used it, and he will discuss with us another perspective for public health. Thank you, Professor.
Thank you very much. Let me see when I can get the screen sharing here. Oops. What about? Oh, this doesn't. I don't get the share screen button here on my. Can you see my presentation?
No, we can't see it.
I am not able to see the green button.
Maybe because you're in the full screen, it's on the top of the screen. If you just move your cursor on the top, it may appear. Or in the bottom.
There happened something. Now it's in the full screen, and here the share screen, right, and then the screen, and then yes.
Yeah.
I do that now. Yes. Is this all right?
Not yet.
Oh, yes, I must go. I have to
Restart, maybe if you restart, Professor, your computer.
We can see your slides, but not in full screen. Maybe could you try once more the full screen?
Yes. So I have clicked the screen and then share. And then Do you see anything better now?
Not yet.
Okay.
Okay, now it's okay.
So this is the second. Let me see how I advance the slides here also. Right. Yes. So we are talking about harm reduction here, and harm reduction is called for in many instances. For example, making cars that are less harmful in accidents, bikes, helmets, etc., etc. For tobacco, it's actually an area which is ideal for harm reduction, and that is because people are mostly using tobacco for the nicotine they get, but nicotine per se is not the very most harmful substance. Actually, it is the combustion process that creates thousands of chemical substances, of whom 60 or so are found to be toxic and harmful. The nicotine is not a substance that you really would like everyone to use, but it doesn't seem to cause respiratory diseases or cancers, and not much cardiovascular either. In Sweden, with the snus, we may see that if you get a stroke or an MI, it gets a little worse if you are using nicotine in the form of snus, but it doesn't increase the risk of prevalence of any of these. And the head of the FDA, Steve Gottlieb, he said in 2018 that nicotine, while highly addictive, is delivered through products on a continuum of risk, and that in order to successfully address cigarette addiction, we must make it possible for current adult smokers who still seek nicotine to get it from alternative and less harmful products. And in Sweden, we have been lucky for quite some time to have had cigarettes more or less replaced by snus. You see here from the end of the 70s, the tobacco used for cigarette has been going down, but snus and nicotine pouches has been going up. And we have also in Sweden reached what is called the end game, with no more than 5% of the adult population smoking. This is a little busy slide, but this is the most important slide I'm showing today and that I can think of actually. And this is data from WHO that have looked at the mortality attributable to tobacco. And we see then the European Union, we see the median for lung cancer, the country with the highest value, and the EU country with the lowest value. The median per 100,000 in European Union for lung cancer is 220. For Sweden, it's 87, so lower than the second lowest country in Europe. If we look at other cancers, it's 105, the average or median, and Sweden has 36. Again, an outlier below any other country. If we go to cardiovascular, we see that there is 170 per 100,000 in the European Union in average, and only 72 in Sweden. And for all causes, 550 compared to 222. So just figure if the entire European Union had had the smoking habits of Sweden, we would have seen something like 350,000 less deaths per year. Below, we have women also. And with women, we don't at all see any reduced incidence of lung cancer and cardiovascular disease. And that is because the snus use is more or less entirely for the men in Sweden. The women are starting to use it a little bit, but they haven't used it for very long. So therefore, it's not the air or any other environmental composition that makes this happen. It's a nice experiment that the man has one effect and the woman doesn't have the effect. So it's probably the tobacco product they are using. Here we see lung cancer incidence and how rapidly it has fallen in Sweden and fallen to very, very low levels. The neighboring country, Norway, are actually seeing some of the same phenomenon that we have seen in Sweden. We are looking here at the relatively young adults, 16 to 24 years old, and from around year 2000, we see that snus has been increasing. Snus has been increasing, and cigarette smoking has been decreasing. This is in men. The entire tobacco use is also trending down. If we look in the women, we see the same, that snus use is going very much up and cigarettes are going very much down. And in young Norwegian young women, the smoking prevalence is around 1 to 2%. Another country which we have seen a picture from already by Dr. Professor Richter, that is Japan. And in Japan, heat but not burned tobacco products have been introduced around 2015. And as they were introduced and became popular, we see that smoking started to fall more rapidly than it would have if we had extrapolated the trend from before the heat but not burned tobacco products. And what is fascinating here is that just a few days ago, I saw that the number of hospitalizations in Japan due to COPD or cardiovascular disease is trending down from at around 2015 when smoking went down, I should say. It's of course smoking that is going down, which is responsible for the reduction in COPD hospitalizations. But the reason that smoking could go so much and all of a sudden down by 1/3 is probably and most likely the heat but not burn success products, the success of those products. Yeah. The next country, which is also of interest, that is New Zealand, as we also already have heard, as electronic cigarettes is trending up here, the cigarette smoking is really going down. And last year it was down at 9.4%. Unfortunately, I don't have any data on real harmfulness in terms of diseases, but I guess that will also come. And it has been much mentioned already, so I'm not going to go any further than saying that in England, they have really embraced the e-cigarettes and are stating that they are far less harmful than cigarette smoking. And we can also see that when e-cigarettes were introduced and became popular, the smoking prevalence curve started to drop faster and deeper. Now, for the last few minutes, I will change topic a little bit and talk about what is called oral nicotine pouches or just nicotine pouches, which is the most recent harm reduction product. And this product contains nicotine, but is but doesn't contain any other tobacco substance than nicotine, which is derived from tobacco. The ingredients are usually cellulose to which nicotine is bound, and then there are a few salts to increase the pH to have a better absorption across the oral mucosa of nicotine. And these salts are the same salts that are usually used in the medicinal nicotine replacement products like nicotine gum and nicotine lozenge. And furthermore, a pouch like this has also been registered as a medicinal product in Sweden. Here you see 24 toxic or potentially toxic substances. And these oral nicotine pouches, 4 different kinds, 4 different brands, have been investigated on these toxic substances and compared with nicotine gum, the medical product, nicotine gum and lozenge. So we have averages here of gum and lozenge, and here we have the average concentration of 4 different brands of nicotine pouches. And we see very, very low levels. There is really no difference between the medicinal and the tobacco company produced and marketed products. So this is even further a step in the harm reduction process. And what we have seen here in Sweden, in Japan, in UK, Norway, that this has happened without demanding and costly interventions from the healthcare system. Normal market mechanisms have been in operation and has been available and effective. The thing is really to make them available. And the funny thing is that Professor Richter mentioned that we do have cigarettes, and no one is actually asking about why not banning cigarettes, or at least making them more difficult to use, availability, price, etc. But that's how the world still operates. I hope we can, and partly a little bit with this seminar, change the world for a better world and less disease and death from harm. Thank you very much from tobacco. Thank you.
We thank you, Professor, for your great presentation. Perfect. It was very nice that you show us a success story for public health, an alternative way without cost, without many efforts from the public health, from the government to regulate a big problem. Thank you very much. Ignatios, do you have something to say?
Are there any questions from the audience that you'd like to ask Professor Fagerström? I think Professor Fagerström, it was an excellent presentation, very clear to us that there is a good example showing the positive effects of harm reduction in terms of numbers regarding public health, regarding lung cancer, regarding cardiovascular disease in the Scandinavian countries. And of course, Japan is following this example using not snus, not pouches, but another heated product. And of course, maybe we will have shortly some evidence that the reduction of smoking and the incorporation of the new heated products will maybe reduce the numbers of lung cancer or other diseases in Japan. And this would be a very interesting example to enhance the harm reduction policy and to adopt this kind of policy in the European countries that are very skeptical yet to these policies. And if there are no other questions, maybe for the sake of time, we would go ahead to another very interesting presentation from Professor Fal. He's also the president of public health in Poland, and we are very eager to hear his views on public health policies of harm reduction. Professor Fall.
Good. Yes, I think I have it already shared. Do you see my presentation? Well, thank you, first of all, for inviting me, and Professor Ikonomidis, thank you for this nice introduction. We're all talking about the harm reduction and introducing of the harm reduction in the policy of every country in terms of reducing the real harm of the habits that are with us, because we know that the risk factors that we used, the old, let's say, risk factors as malnutrition, lack of pure water, lack of sanitation, and so on and so forth, they are gone, at least at present, at least in this part of the world. And we have new risk factors that we need to learn to deal with, because they are responsible for almost 95% of premature death in Europe. So this is a really huge problem. This time I just wanted to look at this from not my first profession, because I'm a pulmonologist, so this is the first thing I do, but to look at it from the public health perspective, and to think what tools were really effective in the past and what tools can be employed in the future to support the techniques, the harm reduction techniques that you were talking about, to support them not only in the mentality of the patients who cannot stop smoking for, well, some reasons, but they also support these techniques in the mentality of those decision makers who maybe can make these techniques to be more active, more available, and therefore more effective in future. Okay, well, this is my conflict of interest. Well, when we look at one of the most well-known graphs, we see that, societies or people in the countries where the GDP or income per capita is higher, they tend to live longer. Yes, they tend to live longer. So let's see that, earning, let's say, $20,000 make you live around 78 to 80 years. When we look at the same graph, but going back a little bit more than 100 years, so, we have also the linear relation between the income and life expectancy, but, the numbers, both in the income, but also mostly in the life expectancy axis, are much, much lower, which means that medicine made a huge, and now, as I already said, medicine is dealing with these modern risks, and the modern risks are quite different. And I think that I can quote here Aldous Huxley, who said, medicine made such a tremendous mistake that there are hardly any healthy people left. So we not only treating and curing people well, but we are diagnosing very broad, and therefore seeing that this urban air quality, overweight, physical inactivity, and most of all tobacco are really causing a lot of trouble, health trouble, including death. When we look at the risk factors, so we have over 30 million deaths worldwide attributable to five main risk factors. And also, when we look at the groups of the chronic diseases, including cancers, we see that the four groups responsible for over 80% of premature non-communicable diseases, death, are the cardiovascular cancers, respiratory diseases, as well as metabolic diseases, most of all diabetes. It's not only that the bad habits that we have are destroying our health, but this reflects in finances, this reflects in an industry. So when we look at the estimates, well, the total burden of diseases, financial burden of diseases, calculated in trillions. Of course, in Europe, it's going to be billions. So in American trillions or European billions of US dollars makes us see that this 5 major groups of diseases, we had 4 in the previous slides, the mental health conditions were not included, but so the 5 major groups of NCDs cause a loss of nearly $100 billion around the globe. When we when we looked at where losing most, it's of course cardiovasculars are the leaders. 50% of the loss is concerned with the cardiovascular diseases. Well, it's diseases itself, the lethal effect, and also the remnants of the disease themselves. And have a look at the right lower corner when you see that the countries and the economies that suffer most are those from the upper middle income group. This is very important because, well, most of Europe is either high income or upper middle income group. So it applies to Europe perfectly, and we need to look at it closer also because the public money in Europe is being used to finance all the social and health care systems. So on one hand, the amount of NCDs increased. On the other hand, the NCDs cause huge losses, as I showed you, around $100 billion worldwide. So we have a rising demand and falling input, which well brings us to some point at which we need to start investing into prophylaxis at every stage of it. But what is investing? Investing is either putting money or putting some policy, well thought and looked ahead policy to put in there. Well, please have a look at the Polish budget or the revenue budget for 2020. We have both the plan, which is lighter blue, and the execution, which is, well, dark blue or even black. Please note that the indirect taxes stand for, well, between 65 and 75% of the total budget. So in this indirect taxes, we have excise tax and we have value-added tax. When we look at the excise tax in Poland, we see that around 30%, 28.1% of this tax comes from cigarette selling. Well, let's imagine a situation that the politicians say, well, we are from tomorrow on, Poland is well, smoke-free, cigarette-free country. No, very nice, but they lose 28% of the biggest chunk, biggest pie in the country budget. In this point, I'd say that well, all the politicians have a conflict of interest making decisions that will lead directly to, well, stop selling all the tobacco products because they lose their precious excise, and they lose also over 5 billion zlotys yearly from the value-added tax that comes only from the cigarette market. So when you look at it, it's well, nearly 18% of the whole budget comes from the cigarette and the surrounding market, which is a very important part of the budget. So when we look at other documents, we see that not only in Poland, but in all the countries, the income from excise tax on cigarettes, it's quite essential. And also taken from the report showed here at the left-hand side, we have three groups of income-divided countries: high-income, middle, and low-income countries. And we see the richer the country, the higher the income per capita is excise or in general tax part is in the price of a cigarette pack is higher. What can the politicians and the decision makers do to keep some of this precious excise income and still act along with the public health needs and the public health sector? Well, once again, for only short moment back to Poland, because these numbers I know simply best. When we look at a cigarette in Poland, we have even more than the average in Europe, because we have 80% of the cigarette price being taxed. Well, this puts Poland in top countries as far as the taxation is concerned. But what happens? It still doesn't, it didn't solve the problem. The cigarette consumption fell in Poland, was falling nicely for many years, but 5 or 7 years ago, it stopped at the level of around 20% of the society smoking, a little more men than women, but still women are fighting forward. And in a couple of years, I think that the proportion will be reversed, but still it's not going to change the fact that 20% of the population keeps smoking. One of the good things is a price change. So once we put higher prices, let's say higher taxes. So we put more excise tax on cigarettes. It will definitely cause consumption change. But we raise the prices by 10%, and the consumption, doesn't fall 10%. In high-income countries, falls around 4%, and low to medium income countries, it falls more, because these countries are more fragile, so are more price sensitive. Still, this is a good thing to some point, to some level, because then we have illegal market, then we have illegal import of cigarettes. We've been through that already, so we have this experience. But still, this is a very good step to increase price by increasing taxes on the most harmful products. In this case, these are cigarettes, because when we go to the alcohol group or to other groups, so we have other substances that are the most harmful. But here are the regular, let's say, traditional cigarettes. So the first move in taxes is to increase taxation of these products. Let's see what happened with this parameter in Europe. Even though Europe has a relatively high taxation on tobacco, as you see, I was showing the leaders, it's over 75% generally. But when we moved from 2007 to 2014, in some countries, the taxation did not rise, example, Germany, but fell, which means that the taxation fell, so the budget income is lower, and the cigarettes are, at least theoretically, more available. This is not, in my opinion, good move. This is not the way to go. We should raise the taxation and support quitters financially. Convince quitters that they have an extra bonus of some money left in the pocket when they quit smoking. Let's see. I'm sorry, that's in Polish. Sorry, translate for you. Let's see at the new regulations introduced in Poland a couple of months ago. Actually, they are right now being introduced formally. We have on one hand the traditional cigarettes, and per 20 cigarettes in a pack, we have around 14 grams of tobacco. On the other hand, we have the innovative heat-not-burn products, and per pack, per 20 pieces, we have 6 grams of tobacco. What happens? Please have a look. The tax on 1 gram of tobacco in this innovative, less harmful, harm-reducing products is almost the same as the tax on 1 gram of tobacco in traditional cigarettes. Well, again, for the second time, this is not the way to go. I said that, well, raising taxation on the products that are most harmful, this time traditional cigarettes, is the right way. But putting the same tax on products that, well, are being introduced to help those who cannot quit, reduce harm, or, well, gave them another chance for quitting, well, this is not the way. However, when we look at the new regulations I told you about in Poland, we see that value-added tax is higher in the traditional cigarettes. So it's not all that bad, these new regulations, but I think that it was a chance to go much, much further, and this chance was not used by the decision makers. Well, I can only say that we will try to influence, as the Public Health Society, we will try again to influence and make an increase, much higher increase than planned, on taxes to traditional cigarettes. Well, except from financial, we have 2 other well-trained, tools for support of cigarette smoking. Well, one of them is tobacco banning. It's very, very useful, very successful. And please look again at Europe. Now we have, again, 2007, and we see that most of Europe was at a good level, direct and some indirect banning. Well, 7 years passed, and we did not make a big progress. Well, Germany made a big progress. Let me remind you that when I was showing the tax increase, Germany was the only country in the United Europe that went the other way, or the other direction than the others. So simply they lowered the taxes, not increased the indirect tax, the direct taxes for cigarettes. But here they made a right move into more banning. And the third tool that is very useful, it's financing and availability, financial availability and technical availability, so legally sold, support to quit. I showed this tool also because Professor Fagerström, in general, we are talking today about the innovative products. Professor showed us the pouches, the e-cigarettes, the heat-not-burn products, and their introduction into different markets caused the decline in typical traditional cigarette consumption, which we find very good from the health care, from the public health point of view. So if we could support also this innovative product, this will not only be for some people the way of harm reducing, but maybe for some people, or hopefully for some people, this will be one step down from cigarette smoking, maybe a start of a way to quit. Well, of course, this is also a matter of taxation. If we lower the excise taxes and the value-added taxes, whatever, on these innovative products, they will become more available. So more people will maybe transfer from the high-priced and high-taxed cigarettes to a lower tax and therefore lower-priced innovative product, including heat or burn pouches or whatever. So this is the third mechanism by which we can, or well, decision makers or the politicians may influence the availability of different products just by stimulating or destimulating, increasing or lowering taxes to this product. So simply tax can be used as a tool in creating behaviors that are, well, risk factors to develop diseases. These taxes can either increase availability of the more of the safer products, let's say less harmful products, or well, make the harmful products available, which I wouldn't understand if it was the case. The final thing I just wanted to share with you is that banning and taxing is the most effective way to act. Please have a look at the history of cigarette sales in the United States, with the tops reaching in the 60s and then lowering, getting down. And of course, this is being almost parallel, but the curve of lung cancer, deaths, morbidity, and death. Please look at the arrows down here and let's see what happened, what helped the decrease of cigarette consumption. First, 1983, federal tax on cigarettes, doubles. Then increasing bans on in-flight smoking. Nicotine replacement medications are become widely available technically and financially. That's what I mentioned before about not taxing things that should help to be healthier. And finally, again, federal tax increase and substantially increased, because this was almost a threefold increase. And we see that all this in a 30-year period, so this is one generation period, reduced the cigarette consumption almost threefold. Well, yeah, the problem is that between action and reaction and effect, there is well, let's say 2 up to 3 decade delay, which for the politicians is not a good news, because they have election every 4 years, so they need very fast effects, and spending on something that will bring effects in 20 years. Well, this is not a very political attitude. So I think that I mean, doctors, public health specialists, we need to strongly support the changes in also tax policy leading to better availability of the harm reduction tools than the availability of those very harmful products. And finally, of course, we should go forward and ask everyone to change bit habits, because as we know from the Lalonde health fields concept, that really our lifestyle is responsible for over 50% for our health. So all other things, all other ones are well far behind this 50-something%. Well, and I think that tobacco products that are going to minimize the harm are well known. Please well, we spoke today about snus, we saw about cigars, but still, and most of all, I speak because of the Polish market, and we see it acting, and we see it happening, of a smokeless, heat not burn. About heat not burn products. Let's tell those decision makers, those that are responsible for financing, that we lose a lot of money every year if we sell these harmful products, and we lose much more than we earn in taxes. Well, I simply think that this message has to be delivered. We had a study looking into direct and indirect costs of COPD in Poland. Actually, it was an EY report that they supervised. And first we calculated the total cost of COPD treatment, so direct cost. It was pharmacotherapy, hospital, general practitioners, and so on and so forth. The data came from the National Health Fund, and as you know, National Health Fund, is a monopson, so actually is a payer for over 80% of all the medical services in the market. So when we looked at this, we came up to 500 million zloty, 500 million zlotys. But when we look at the indirect costs, especially at the absentees and presentees, we came up with the 10-fold, well, even 12-fold higher amounts. So we need to understand, and we need to spread the message that, first of all, financial tools are very important.
Professor, can you hurry up, please, because we're running out of our time.
Professor, this is the last slide, and I leave you with that this tool, first of all, is very effective. And secondly, it brings money even at the day of introduction. We do not have to wait 20 years to have, well, financial profits from damage reduction. Thank you very much.
We thank you, Professor, for your presentation.
Natasha, I think it was an excellent presentation, yes, pointing out that if we need to think of harm reduction, we need to increase the taxes in the conventional cigarettes and improve access to other forms of nicotine delivery systems. And I would also grab the opportunity to say that the support to quit smoking also includes smoking cessation programs, medically assisted smoking cessation programs, and the authorities should compensate the use of nicotine delivery systems, whether these are chewing gums or patches, or whether these are medicines like varenicline, for example. In Greece, in CAD patients, the state compensated for a CAD patient the varenicline use to quit smoking, but after the financial problems we had, this went out, and this approach should be presented in the European Union to have a common line on that, to support medically assisted smoking cessation products, and of course to embrace the harm reduction policies using other ways to deliver nicotine. I don't know, Natasha maybe, and Professor Fal would like to have a last word.
Yeah. Thank you. Once again, thank you very much for the opportunity to speak today. And yes, I absolutely agree with what Professor Ikonomidis just said. Well, we need to introduce it, and we need to, I think, prepare a paper, position paper, showing what's the situation with the taxes and availability of therapies and harm reduction products in the countries we're coming from. And when we put it together, then maybe we will, draw up well, some real pressure, and finally decrease the availability of harmful cigarettes, and try to put this money that we saved here to, well, the protocols that you told about, those trying to save people. This would be a nice idea. This would be a nice thing to prepare such a paper, a position paper in the future.
Yes, our main idea is to stop smoking.
Oh,
not,
yes. Well, this is at the end, but
not to switch.
Not all of the patients are ready for this.
Okay.
Well, this is a disease. They are. This is a disease. We need to treat them.
Okay.
And not to leave them with the problem.
And of course, we need the financial support of all smoking cessation products, because at the end we have to try everything, and then if nothing works, and we have data that's even if we use a medically assisted program, then about 50%, we have 50% relapses. So we need to have another weapon in our, another weapon to face the relapses, and harm reduction policies may offer this weapon.
Of course, we have to try.
Professor Fagerström has something to add.
Yes, we are talking about smokers and patients, but we are talking about a drug addiction also. And drug addictions are not easy to eliminate or reduce. Unfortunately, at least for me, I have seen some data from the United States where cannabis has been legalized, that as much as cannabis goes up, smoking goes down. And so there seemed to be a little bit like two communicating yards. And some of the smokers, they can give up smoking if they have access to marijuana and cannabis. So this is not easy, and to treat everyone to stop is not possible either, because this is not a small group of patients. This is 10, 15, 20 or more % of the population in some countries. So therefore it has to be solved, not just, but of course also by physicians and therapists, but it has to use other means as well, as taxation, etc., as Professor Fall was mentioning. Thank you.
So we're ready now to finish and close our table. We haven't any question of our audience, but it was a very good round table in our Congress. That's why we thank you very much. Ignatios, can you close our table?
Yes, I would like to thank all the esteemed speakers, and I hope we get the chance to discuss on these hot issues in the future. Thank you, Professor Fall. Thank you, Professor Fagerström and Dr. Richter, for presenting us the latest news on harm reduction policies over the world, in Europe, and how to be effective in reducing conventional smoking habit and improve public health. Thanks a lot.
Thank you very much.
Bye-bye.
Bye.